I have the pleasure to introduce the next presenter. It's Professor Tim Kendall from the University of Edinburgh, and he will present the research on the hidden role of pathology in the cholangiocarcinoma patient's clinical journey. Tim, the floor is yours.
Thank you, Helen, for inviting me to talk about this again. I'm just going to really explain pathology and the power of working together. It's kind of as simple as that. I'm not giving any proper pathology as Matt would recognise, unfortunately, or perhaps fortunately. I'm going to use pictures as much as possible and take you through the role of pathology in the patient journey. Now, pathology, the word, comes from ancient Greek for pathos, meaning suffering, and ology, meaning study of. So it's got a branding issue. Study of suffering isn't great. This is the Royal College definition, which kind of presents us in a better light as the study of disease, bridging the gap between science and medicine. It's described as the science behind the cure. My colleagues occasionally have called it the art behind the science behind the cure. It's a bit artistic in the way that Hassan mentioned for surgery. I'm a histopathologist, which means I look at tissue, so cells in context. On the right is a H&E section of normal-ish, I think, liver. This is our workhorse stain, pink and purple. They're just dyes. One of them comes from, or used to come from, tree bark, and it allows us to look at it. And all I do really is look at these pictures and say what I think. But that helps make a diagnosis and it helps to find treatment. But pathology, as well as having a branding issue based on its name, is kind of physically, metaphorically hidden. That's the front door to the department I work in the Royal Infirmary of Edinburgh, and you'll spot it doesn't have any labels. It just says no visitors, and you need no lab coats on the side of the corridor, but it's often unmarked, and often they're in basements. We're not in the basement, fortunately. But I'm not really going to tell you about pathology. I'm going to tell you about the team, because pathology is like medicine. It's like life, really. It's about the people, the relationships, about the companions we share our journeys with. So really what I do is the kind of sharpish end of a massive team effort. You won't ever know the people in laboratory medicine. Hopefully you won't ever need them. But if you do, and in secret, they'll be there and they'll be helping you. So I'm going to follow a specimen as it comes through the department. So this might be a biopsy. It might be the surgical specimen that comes out if you've had an operation. The first thing that happens is it goes into formalin. Formalin's a clear, slightly toxic, or very toxic, depending on who you talk to, liquid that glues together proteins. It does a similar thing, I guess, to when you boil an egg. It turns it from squishy and messy into something a bit more solid. That allows us to cut it very, very thinly and look at it. If it's a large specimen, we, the pathologists, look at it in that bench on the left-hand side there, the trimming bench, where we describe it, we cut it into small slices, thin slices, and take the bits that we want to look at to define diagnosis and define where, if it's a tumour, where it's invaded, and the margins and the information that define management. If it's a biopsy, it just goes straight to the other end of the same room on the right-hand side, and the scientists clip it up. What that means is they take the small bit out of a pot and they put it into a small plastic cage called a cassette. We put the bigger bits into the cassettes on the left. We in Edinburgh, I think, do about 80,000 cases a year, and that generates probably about 400,000 cassettes a year, just to give you some sense of scale. And that serves a population of about 500,000. So if you think about the UK, there's a lot of cassettes around. Those cassettes have to go through a process, or processing, helpfully enough, which involves taking the water and the lipid, the fat, out of the tissue, so that we can then keep the tissue basically forever. And they go through the processing in those machines on the left. Once the tissue is processed, what we need to do is make them able to survive basically forever and allow us to cut them very, very thinly. So we add wax to it, paraffin wax. And that happens in this room on the right. The floor, you can see it's slightly got a white sheen. It's really skiddy if you go in there with leather-soled shoes because of all the kind of wax floating around. The wax imbues and surrounds all the tissue, and when it sets, it means we can take very, very, very thin slices, and it means that block will stay basically forever, and we can come back to it if we want and cut another section. Once the wax is cooled, we cut these very thin sections. Now, we typically cut 3, 4, 5 micron thick sections. That's 3, 4, 5 1,000th of a millimeter thick. What that means is we can shine, after staining it, shine light through it and look down on it. So it's super, super thin. And the sectioning is done on the left-hand side there. It's incredibly technical. It uses a microtome, very, very sharp blade to cut very, very thin sections. I can't do it. It's very difficult. The scientists do it, and it's essential to allowing us to look at what we need to look at. Once the sections are cut and mounted, so that it gets floated onto a glass slide, and it's still clear, basically. It's wax and clear, and it needs to be stained. So the machines on the right take these glass slides and essentially sequentially dip the sections through the different stains, the H&E stains or the special stains are done by hand. Probably takes about 90 minutes to dip through. They're constantly in use. And you end up with a stain section that we get mounted, which is where a little bit of clear kind of glue basically drops onto it, and then you put a glass cover slip on top, and then that glass slide can, if you look after it, can then also stay forever. Those are the glass slides, the stain sections that come to the pathologist. So that's my desk on the left-hand side, and that's my microscope. It's got a slightly higher set of eyepieces because I'm a bit taller than most. And all we do is put it on the stage and shine light underneath it, look down the top, and say what we think. That's kind of it, really. Sometimes, increasingly now, we're scanning the slide, and the machine on the right-hand side is actually just next to my desk. It's the research scanner. So we create a very high-resolution image, digital, equivalent to a digital photograph, really. That allows some of the digital pathology tools to be developed and applied to those images that will probably, in the fullness of time, make me redundant because the computers will take over. Hopefully, the computers will do things that we struggle to do, and we will augment one another, but we'll see whether that happens or not. So that's the initial phase of what I look at, or what we as pathologists look at. But sometimes we need to do some additional stains, and Matt's mentioned immunohistochemistry, where we look to see whether a particular tumour or a particular piece of tissue expresses or contains a particular marker. And so we put some antibodies on that are directed against the thing we want to know if it's there or not, and if it is, it goes brown, and we look for the brown, as Matt showed you. The lab on the left, that's one end of it, is the immunohistochemistry lab, and there's a whole other fleet of scientists in there that do this staining and develop the stains, validate the stains so that they're incredibly consistent, and we always get the result we are looking for, and we are confident in the result if it's negative. The machines on the right are the automated stainers to do this immunohistochemical staining. So that's a whole other different group of scientists involved. That used to be where we stopped, but as Matt has told you about, there's now lots of molecular tools that we can apply either for diagnosis or for treatment defining decisions. So we now, in Edinburgh, our molecular pathology lab is integrated into the same department. It's just across the corridor from me. We don't have to send anything away, which is very, very helpful. So when we want molecular testing, the same block, the one that's fixed in wax, they cut some more sections from that or some scrolls from that, and then can extract the DNA, extract the RNA, as is happening on the left, and then run it through various different machines, as you see on the right, to provide us with the different tests, the different results that define treatment in the way that, you've heard about today, and you will hear about tomorrow as well. The machines that undertake the molecular testing generate an awful lot of data, but it needs to be interpreted. It's not just a yes/no result very often. It's incredibly complicated, and another whole level of expertise is needed to interpret the results, to turn that into the reports, the sort that Matt showed you. And so that on the left is our molecular pathology office, and they do the interpretation, the scientists in there do the interpretation of the outputs from these molecular pathology machines. All of that needs to be turned into a typed report, the thing that eventually comes across one of your desks, or on the electronic healthcare record now more often. And so we have a lot of administrative staff that basically keep the department running, otherwise it all falls apart. They do the typing, they organise all the meetings that we come through. So conservatively, if you have a biopsy or surgery, there's probably minimum of a dozen different people will be contributing to the processing, to the generation of the report that comes out with one of our names on it. It's more likely to be 20 or plus. Now, there's power in working together. Now, this is where I would have stopped last year when I did this talk. However, at that time, we in Scotland couldn't test for IDH1 mutations, even though there was a drug for it. But as a direct consequence of this meeting, conversations with Benjamin, with Helen, we organised a stakeholder meeting in the autumn in Scotland. Direct consequence of that was that Sophie McAfee, who might be online, is one of the molecular pathologists, was able to find some funding to at least temporarily now test for IDH1 mutations in patients in Scotland. We started testing the day before the big storm in January. It's a temporary measure, so this battle is not won, and there's an MMF meeting in Holyrood in June where we will continue with significant support from Benjamin on that to fight that good fight. As it will have been apparent, now we need tissue to define treatment, which means we need tissue for research. A short historical lesson, this has been problematic, and it was problematic because in the past, up to the late 90s, pathologists typically, but not always, were using tissue in a way that they shouldn't have been. So it was wrong then and it's wrong now. This was the organ retention scandal and all the hay and some of the names that you'll have been familiar with. As a direct consequence of that, there was a kind of shutting down of the use of tissue for research. It was a kind of reaction to it. It was entirely understandable. But it was recognised at the time that it was possible that there could have been an overcorrection. Now, this is 20 years ago. Since then, the utility of that tissue, the necessity of using that tissue for research has increased, particularly recently. So one of the things I spoke about last year, and I'm still doing, is undertaking an exercise with the Pathological Society, which is a research body for pathologists in the UK, to get a picture of what are the public and patient attitudes to the use of tissue for research. Now, this is twofold. If you think about it in two directions, I mentioned I thought there were 400,000 slides from Edinburgh a year. We have to keep the slides for 10 years. We keep the blocks, so there are 400,000 blocks. We keep the blocks for 30 years. So that's about 12 million blocks from Edinburgh. Edinburgh is about 500,000. If you scale that up to the UK, imagine the number of blocks that are kept, and they're often kept in a cave in Wales because it's a good storage area. The amount of information stored in those blocks, if we could get at it, will inform so much. So the question is, can we? And this is where support from you, support from the public is a necessity. Now, this is where I stopped last year. There's a screenwriting maxim, I guess, show, don't tell. So if you write a film, let's say, you don't have two characters talking to each other, one explaining what's going on to the other. Show things to allow the audience to understand it. So it's no good me saying, you should do this, pathology department should do the other. We should be doing it to allow others to see what we're doing. And we kind of are in Edinburgh now. Our bioresource is a mechanism to access that 30-year block archive. We've got ethical permission to allow unconsented access for research. People apply for research, we review, and research groups can have the tissue for that. But we can do it prospectively as well, so forward. That allows us to consent the patients, which is what we ideally want to do. And Rachel set up the hepatobiliary prospective bioresource collection to allow fresh sampling of liver surgery specimens. The value of having fresh sampling is it doesn't go through that fixation process that glues the proteins together. That stops you doing some types of analysis. So if you can get some fresh as well, ideal. We're very fortunate to have a consenter and member of staff called Erin working on this project. Over the last 18 months, but since we've been running it, she has embedded in the surgical unit, consented 129 or approached 129 patients. We want to know where the patients support research. 128 of those 129 patients have agreed. Why is that? Well, I inherently believe that people are good. So even patients at their darkest time are still thinking, how can I help others? So we've now got this resource. These are the figures for the diagnosis that we've collected the patients from. You can see cholangiocarcinoma there is the third most common specimen. This just reflects the activity of the surgical unit. So we've got this resource, and we are being empowered by our patients to use that for research, to help others use that for research, to find things out. So what Rachel and I don't want is freezers full of tissue. What we want is empty freezers, because that means it's been used and we've found things out. I'll stop there. Thank you.